Well, we're very encouraged, Don, by what we've seen with the progression-free survival benefit from the 3 drugs over the 2. Just to remind you, we saw a median progression-free survival approaching 12 months for the 3 drugs and approximately 6 months for the pomalidomide and dex in the control group. And this was highly significant and had a hazard ratio of around 0.56. When we looked at the lenalidomide refractory patients, we saw in fact that the hazard ratio was even stronger at 0.5 in favor of the 3 drugs over the 2. So what we're showing is that in relapsed refractory patients, all of whom have received proteasome inhibition, all of whom have received lenalidomide, and in fact over 90% of them were lenalidomide refractory, we're able to show that the 3-drug platform is clearly clinically more efficacious than the 2-drug control. What was also very interesting in our analysis was that the high-risk patients got benefit from the 3 drugs over the 2. We saw also a significant improvement in renal function for patients with renal impairment. And in addition to that, we were able to offer this combination to a broad range of patients. And in fact, we had substantial representation of patients over the age of 70. So clearly this is a very active combination that's generally well tolerated. So in key high-risk subgroups, it's active. Overall, it's active. And what's most important as well, Don, is we showed a trend towards an overall survival benefit already with median follow-up of only just about a year. And when you look then at response rates, they're about double for the 3 drugs over the 2. When you look at MRD negativity, with an exploratory approach that we did, 5% for the 3 drugs, 0 for the 2. And when we looked at time to next therapy, it was about 9 months for the 2 drugs, a median. It wasn't even reached for the 3, and that's an important clinical parameter. Very important for our clinical audience as well is that those patients who were receiving salvage after the pomalidomide and dexamethasone had failed them, over 50% went on to receive daratumumab. Despite doing that, there still was a trend against that group for survival benefit. So therefore, that suggests at least, and it's early, but it suggests keeping your CD38 antibody in reserve doesn't make sense. You should bring it forward earlier in this relapsed refractory population.